Thank you for joining us today. I am Mike Schneider, member of the class of 73 and a member of the School of Medicine and Dentistry class of 77. I am one of the many proud and engaged U of R alumni. I previously had the privilege to serve as the president of the Medical School Alumni Council. Presently, I'm a member of the University of Rochester Alumni Board. A group of 24 members representing each of the university schools with a specific purpose of engaging all alumni and students in lifelong connections with each other and with the university. Today's lecture is part of a series triggered by the Alumni Board and launched back in April called Experience Rochester, which exemplifies the university's commitment to lifelong learning. The series features topics, speakers who are unique to our university. As with previous sessions, we have a broad range of registrants joining us. Students, both current, prospective, and admitted, parents, and alumni as far back as the great class of 1946. Successful universities are about acquiring and producing knowledge and translating that knowledge into deliverables. Today, we will share one of our university's successes. We are joined by a panel of experts from the university's medical center who are doing groundbreaking work to help us treat, track, and prevent COVID-19 from spreading. They will share the latest information on vaccine distribution, vaccine trials for children, and research on the new strains of the virus. At the end of the session, our panelists will answer as many questions as allowed by time. You can put your questions into the Q&A box at the bottom of the screen. Stephen Dewhurst, Vice Dean for Research at the School of Medicine and Dentistry, will both moderate and introduce our participants. Thank you again for joining us. Now the Zoom spotlight moves to Stephen.
Hi, thanks very much for that introduction, Dr. Schneider. So it's a real pleasure to be able to introduce just a totally fabulous panel of people who'll be speaking today. And just to maybe contextualize a little bit about the university's history in this area, we have a long-standing history of just excellence in infectious disease research in particular. And that's going to be very evident as we go through the conversation today. So as many of you are very familiar, the university is the place where the Haemophilus influenza B vaccine was developed, actually in the Department of Pediatrics. So one of our speakers is from pediatrics. And that vaccine essentially wiped out a major cause of childhood illness, and it just disappeared. And it disappeared because of the work of a really committed clinician scientist and a team of other scientists working with that person who made that happen. More recently, the Infectious Diseases Division in the Department of Medicine, which several of our speakers are from that division, was the hub for the creation of knowledge that led to the development of the human papillomavirus vaccine. That's the first vaccine for cancer, successfully prevents cervical cancer and other forms of cancer that affect hundreds of thousands of people globally on an annual basis. It has been transformational to global health. And that originated in large measure here at the University of Rochester in the infectious disease clinic. So we've really had over a long time excellence in studies of many viral pathogens, many of them respiratory, such as respiratory syncytial virus, influenza. One of our speakers heads a major center nationally in the studies of influenza. And in addition, we also obviously are a hub for work on HIV. One of the interesting things about the COVID pandemic is that we've created structures, infrastructure, outreach efforts, and vaccine trial units that we've been able to deploy or redeploy. So one of our major HIV clinical trials units has been redeployed to do a lot of work on COVID vaccination. And again, because that's based in our infectious disease division, it's really been a great opportunity for a lot of synergy between different investigators with common interests at stopping this pandemic and figuring out what are the most effective both treatments and vaccines. So there are several clinical trials related to coronavirus here at the university that have either are currently in progress or have already been completed. So as you're all very well aware, the Pfizer and Moderna vaccines have been approved. AstraZeneca vaccine is based on a slightly different technology. That one has not yet been approved, but is expected to be approved quite soon. And there's another vaccine from Johnson & Johnson that is a little behind the AstraZeneca, but not far. Two of those are based on RNA technology, a brand new technology in vaccine development, Pfizer and Moderna. Two of them are based on adenovirus technology, that's AstraZeneca and J&J. And in large part, that technology has been refined through studies of HIV vaccines. So there's, I think, a really important synergy in many of the things we've learned from one field of scientific endeavor have ended up feeding into other fields and allowed us to really advance very quickly in this space. And that, that's, I think, one of the amazing things about really, it's astounding how far we've been able to advance in COVID vaccine development in such a short time, that now we're talking about questions of vaccine distribution. It's a fantastically fortunate place to be that we are able to have that discussion. And I do think sometimes it's worth just taking a step back to pinch ourselves a little, remind ourselves what an incredible advance that has been. U of R has a lead role in the trials of the AstraZeneca vaccine. And I imagine that Anne or Angela may speak a little to that. Also important to say that there are many things we don't know about vaccines. One of the most important spaces where we have a knowledge gap is really, are these vaccines effective in children? And how are they most effective? And there are, that's a really important question. And so we're now moving forward with trials in children, and our first speaker will address that issue in just a moment. The last thing to say is there are multiple trials obviously ongoing of vaccines I haven't spoken about, and they may come up during the course of conversation. So I'm going to just stop my introductory remarks now and turn it to our first panelist, and that's Dr. Mary Caserta. She's professor of medicine, in the Department of Pediatrics. She's a specialist in viral pathogens, and I've had the pleasure of knowing Mary for quite a long while now at the university. We've collaborated over time on studies of other viruses. So Mary.
Thank you very much. Appreciate you inviting me today. As mentioned, I specialize in pediatric infectious diseases, and I want to spend just a couple of minutes reviewing some of the information about COVID and COVID vaccines in children. Can I have the next slide, please? The data on this slide are taken from a collaboration between the American Academy of Pediatrics and the Children's Hospital Association and reflect trends in publicly reported data through January 21 of this year, so very recent data. Although the incidence of COVID appears to be lower in children overall, there have been over 2.6 million cases of COVID infection identified in children in the United States. This compares to a total of about 21 million cases in the entire population, so that children make up a minority of the reported cases. Children are also tested less frequently, though, with only 6 to 18% of the testing done in children, and the positivity rate in children has ranged between 7 and approximately 28%. Indeed, the hospitalization rate for COVID is thankfully much lower in children than in adults, with only 1 to 3% of pediatric cases hospitalized, with a very small number of deaths. Next slide, please. So the burden of cases of COVID in children is regional, as it is in adults. There's been a recent, very significant surge in the West Coast, with California really leading the way there. 6 states are now reporting over 100,000 cases of COVID in children. Next slide, please. Unfortunately, in addition to acute disease due to COVID, it appears as though children are more prone to suffer from a secondary disease associated with COVID. This new disease is called multi-system inflammatory syndrome in children, or MIS-C. And we're still learning a lot about it, just how and why this happens. For now, we just have a clinical description of the syndrome, and it includes total body inflammation, and it manifests as fever and organ involvement. And the organs most commonly involved include the heart, lungs, kidneys, brain, skin, eyes, and the GI tract. Although the cause is currently unknown, it does very much appear to be an illness that follows a COVID infection, even an asymptomatic COVID infection in a child. Excuse me. And also, MIS-A, or multi-system inflammatory syndrome in adults, is also now being reported. Next slide, please. The CDC is tracking this disorder, and currently there are over 1,600 cases in children and 26 deaths reported nationwide. And I know we are seeing cases here at the Children's Hospital. And the cases of MIS-C follow the waves of cases. So we expect we'll still be seeing a fair number of these cases for the next several weeks. Next slide, please. So COVID does cause severe disease in children, either directly or indirectly. And thankfully, the manufacturers are now working on bringing vaccine trials to children. So in the future, we can include them in our vaccination efforts. This table shows that Pfizer, Moderna, J&J, Janssen, and AstraZeneca all have pediatric trials planned or in the process of doing the early phases of these trials in children. In general, the trials will include children, some down to 6 months of age, and initially will be earlier phase studies with dose finding and age de-escalation. And what that is a quick way of saying is that the same dose used for adults may not be the right dose for children. Often doses of vaccines are different between children and adults. So early parts of these studies will include dose finding studies. And in addition, often vaccine studies are age de-escalation, which means that the older children, trials in older children are the first to begin, and once safety is established at each age group, then younger age cohorts are enrolled in studies. So dose finding and age de-escalation are parts of these studies. My understanding is these studies will definitely focus on safety, tolerability, and immunogenicity, being basically measuring how much immune response is measured to the vaccine. And once we find a number, meaning that we identify how much antibody is needed in a child's blood to protect them, then we'll be able to move much more quickly, because children do not get as ill as adults, it appears. It would take a very long time to do the same sorts of efficacy trials in children as have been done in adults. So that we're hoping there will be what's called a correlate of protection. We'll be able to identify from measuring what's going on in children after vaccination, whether the vaccine will be successful or not in children. And if we can find that level of protection, then we'll be able to move much more swiftly. Right now, I know Moderna and Pfizer have early phases of their studies ongoing, and we're hopeful at the U of R we'll be able to become involved in the later phases of these studies coming in the next month or so. And that's it for me.
Thank you very much, Mary. That was terrific. Our next two speakers are going to speak about emerging SARS-CoV-2 variants, and I'm going to introduce both speakers at the same time. So the first speaker here, as you can see from his title on the slide, is Dave Topham. He's the Marie Curran Wilson and Joseph Chamberlain Wilson Professor in the Center for Vaccine Biology and Immunology and the Department of Microbiology and Immunology. He's also the director of our National SEER Center, which is a Center of Excellence for Studies on Influenza Virus and Influenza Infection. Joining him in this session will be Dr. Ann Falsey. Ann is a member of our Infectious Diseases Division. She is the co-director of our VTEU, that's our vaccine trials an evaluation unit. So that's really been the lead entity at the institution involved in the evaluation of new COVID vaccines. Her co-investigator or her co-principal investigator will be speaking right after this. So Anne is really a world-leading expert in the area of respiratory pathogens, respiratory viral pathogens in particular, as is Dave. So we're really very lucky to have them both join us. And thank you both.
So next slide. Good afternoon, everybody. Thanks for joining us. I'm sure if you've been paying attention to the news, you've heard that there are a number of SARS-CoV-2 variants that have emerged in different parts of the world. These were first seen as early as September of last year. In the United Kingdom, a new variant known as B.1.1.7 emerged with an unusually large number of mutations, many of them in the spike protein, which is the protein the virus uses to attach to cells. In South Africa, there's another variant. They go by various names, but I try to pick the most popular one, B.1.351. This one is of particular concern. It hasn't spread too far out of South Africa yet, as far as we know, but it does seem to be able to evade immunity conveyed by infection. It's a little less clear how well it evades immunity provided by vaccination, but there's evidence that it does, and it can escape from several of the monoclonal antibodies that have been developed to use therapeutically in patients. In Brazil, there's another variant known as P1 that is also now present in the United States. Both the United Kingdom and the Brazil variant, there's evidence that current vaccines will protect against those strains. There's much less evidence for the Brazilian strain, but I'm sure those studies are being done as we speak. Next slide. So the presence of the UK variant in the United States is variable. This is a recent graphic from the CDC. So the darker blue states have more cases than the lighter blue states, but the numbers are still fairly small, in the tens or single digits. Now that may change quickly. These variants seem to be more contagious or more able to spread. They don't seem to cause more disease once they spread, but there's the possibility that they're going to infect more people. And when that happens, you're going to just have more disease. And the adaptations that are occurring are probably adaptations as the viruses adapt to the human host. They become more efficient. And in particular, most of the mutations seem to affect the receptor binding domain, making it basically stickier for the cells. So you can get infected possibly by a lower dose. Next slide. Now I'll turn it over to Ann Falsey.
Okay, this is Ann. Hi, everybody. Next slide. So I thought I would elaborate a little bit on what Dr. Topham said and try to provide some graphics to illustrate what we're talking about. And these are RNA viruses, and all RNA viruses mutate rather rapidly. It's just what they do. Some mutations are silent. Some mutations lead to a virus not being what we call as fit. That means it's detrimental to the virus and it doesn't continue to replicate. And some viruses provide advantage. And so this is a shot of the mutations over time very early when this virus emerged last year. And it shows that the Asia strain is shown primarily in blue dots, but once it got to Africa, the number of mutations really delineated a new variant, and that's shown in sort of the yellow dots. And it shows the rates of mutations over time. Next slide. And so although we're talking a lot about these new variants, it was quite clear at the very beginning of the epidemic that the original Wuhan isolate, which was had a mutation in the spike protein at position number 614, you can see with the map of the world that it's sort of blue, and that once it actually got to Europe, there was this single mutation, and that strain that spread in Europe actually became the dominant strain worldwide. Now, in order for a virus to do that, it has to have some advantage, you know, whether it's more transmissible or it just makes that virus replicate better. It has to have some advantage that it would take over and become the dominant strain. And so this is not a brand new phenomenon. And with this strain, they've had time to do some experiments, and they did find that the European strain, let's call it, did actually replicate more efficiently in the noses of animals. And so it was quite sensible to say, well, okay, this would spread more rapidly. It's in your upper airways. Next slide. So as Dr. Topham talked about, this new variant, that's the B117, that's coming out of the United Kingdom. You can see on the left-hand slide, again, one of these graphs of the number of mutations over time. That new lineage is really quite different. You know, the little dots show the number of changes. And so there's this, I don't know if you can see my arrow, but there's a line that shows the typical changes over time, and that how this new lineage is quite different. And as he mentioned, there's an unusually high number of mutations in the spike protein, but the blue arrow shows one that's quite important. And that one is also found in the spike protein in the South African variant. Next slide. Oh, next slide. And this is just a schematic of the receptor binding domain on the spike protein. And the receptor binding domain is where that protein actually attaches to your cellular receptor, which is known as the ACE2 receptor. So on your respiratory epithelium, there are ACE2 receptors. And what this little graphic shows is that that 501, which is sort of buried in the center of the receptor binding domain, it's actually quite critical for attachment of this variant to your cellular receptor. And there's just very preliminary data that indicates that perhaps this strain binds more avidly, tightly. And so that might be an explanation for why it seems to spread and be taking over as the dominant strain. Things move so quickly in this field. I am not aware of any new data where it shows that it replicates to higher amounts or longer or better in upper airways. But those data, those experiments are being done. Next slide. So obviously a big concern is whether or not this new strain is more deadly. Initially, most experts were saying probably not. There was no indication. But just recently, the UK's chief science advisor, some fellow named Patrick Vallance, suggested that maybe they were seeing some increased mortality. So the average mortality for a person in their 60s would be roughly 10 out of 1,000. With the new variant, they were saying maybe 13, 14 out of 1,000. So not a dramatic difference. But I think you also have to consider that this is very multifactorial. That if a healthcare system starts to have so many cases that they are really overwhelmed, you could have increased mortality just due to resources. So it's not clearly more pathogenic. Michael Alsterholm, who is the director of the Center for Infectious Disease and Research at the University of Minnesota, said that he reviewed the UK report and was absolutely convinced the new variant is deadlier. He said that the evidence is mounting, but he wasn't able to share. You know, he's a bit of a controversial figure. He's a member of the Biden transition team. So I think, you know, I don't think there's a reason to panic. I think we all need to wait for the data. Next slide. And then lastly, another big concern is whether or not the current vaccines will work. There's, again, limited data, and some of it is conflicting. It is reassuring that a study of 20 individuals who were immunized with the Pfizer vaccine seemed to neutralize at least the UK strain just as well as prior strains. It does contain that 501 mutation, which is also found in the Brazilian strain, the South African strain. On the other hand, there have been a few reports that convalescent plasma from people who recovered from the infection did not neutralize the South African variant. So that is a reason for some concern. And I think that those of us in the science community would always be concerned about the monoclonal antibody treatments that you hear being developed, because by the nature of a monoclonal antibody, it binds to only one specific region on the protein. So if you have a mutation, that would completely inactivate this antibody. And that's why some of the antibody preparations are being studied in what we call cocktails. So they may have 2 or 3 monoclonal antibodies to overcome that problem. So it's also important to realize that the current vaccines that are moving forward, they induce an immune response to the entire spike protein. And therefore, you get what we call a polyclonal. There's a lot of different kinds of antibodies that are being produced. And so while over time, it might be that there is less efficacy, we would not expect these vaccines to be ineffective. Next slide. So I'll stop there and turn it over to Dr. Bennett.
Thank you very much. So our next 2 speakers will be speaking directly one after the other. So the first of those 2 speakers is Nana Bennett. Nana wears a lot of hats. She'll be speaking principally about one of those hats, which is leading Monroe County's vaccine rollout program. She's also the co-director of our Clinical and Translational Science Institute, the director of our Center for Community Health and Prevention, and leading efforts institutionally to develop a new Office of Health Equity Research. Nana will be followed by Dr. Angela Branch, who's going to be our final speaker. Angela is an assistant professor in the Department of Medicine. As I mentioned previously, she is the co-director of our vaccine testing unit with Dr. Falsey, and they really together are leading this effort of COVID vaccination studies in the local community. So with that, Nana.
Thank you very much, Steve, and good afternoon, everyone. I'm going to change us from science to implementation. This is really the end of the translational spectrum. We can make a great vaccine, but if we can't get into arms, we won't prevent COVID-19. The University of Rochester has been selected to lead the Finger Lakes region in disseminating this vaccine and getting it into arms. And I just thought I'd tell you a little bit about what that means and some of the challenges we're facing. I'll be talking about our specific region, but I think many of the issues we're facing are the same that are being faced across the country. So I think a lot of what we're doing is quite applicable to other regions. New York State decided to divide up the state into 10 regions and to establish a hub in each region. And the University of Rochester Medical Center is the hub, and I'm the lead of the hub, at least for the time being. Our role is to plan, facilitate, and execute a plan to get everyone in our 9-county region vaccinated. Our specific focus is to ensure that the way this vaccine gets rolled out is equitable, transparent, and efficient. And sometimes those 3 values can be in conflict with one another. But those are really our guiding stars for how we want to ensure that everyone gets vaccinated. If I could have the next slide. So this is our region, just to remind you, it's Monroe County and the 8 counties that surround Monroe County. And we are blessed with the Finger Lakes in our region, and that's what our region is called. If I could have the next slide. This slide just is to indicate to you that it takes a network. This is not anything, a task that can be accomplished by a few people or even a small team. It's our entire community. We all need to work together to get everyone vaccinated. And these are just some of the players in our network. We have a very large task force that is overseeing these efforts. And then we have a number of smaller teams that are actually doing the on-the-ground work. But what's important to notice is that every single person in our country is going to have to be engaged in this vaccination effort in one way or another. It may just be communicating to people you know and care about the value of the vaccine and encouraging them to get vaccinated, or it may be that you'll actually volunteer to help administer vaccine. The task is enormous to vaccinate our 300 million adults in the US. And in our region, it's 1.2 million, which is tiny by comparison, but the problems are the same across the entire system. If I could have the next slide. So I wanted to say a few words about eligibility because this has been controversial in a lot of places. The National Academy of Medicine and the Advisory Committee on Immunization Practices thought long and hard about how to prioritize populations, knowing that there would be inadequate vaccine supplies at the very beginning. When they made these decisions, they valued two specific things. One was severity of disease and risk of death, and the other was the risk of exposure. And thus they developed a set of recommendations for who should be vaccinated first. One of the other underlying principles was equity. As we all have known and we've talked about in some depth, we know that people of color are at greater risk for contracting COVID-19 and going on to being hospitalized and dying. So these considerations took equity into consideration at every step. And in New York State, we're pretty much following those guidelines, those national guidelines. So for us, phase 1A is healthcare workers and long-term care staff and residents. And phase 1B is essential workers and also those over the age of 65. If I could have the next slide. So in thinking about how to actually do these groups of people, New York State has created really a fairly sensible system where public health is asked to do all of essential workers, and healthcare systems and pharmacies are asked to do patients over the age of 65. This will continue to roll out. Hospitals are prepared to vaccinate their patients, and as are federally qualified health centers. Pharmacies can also offer vaccine, and then there will be large public facilities for additional people who might not have a physician or who are being vaccinated early because of their job. And if I could have the next slide, I think I'm done. Angela's going to talk a little bit about vaccine hesitancy, which is the flip side of the coin. We're facing incredible demand for vaccines that we don't have yet, but there are also pockets of hesitancy that are very, very important to address. Thank you.
Thanks, Nana. If I can have the next slide, please. So Nana's right. I think right now we're not dealing with an issue of hesitancy. We're dealing with one of demand. We have patients calling the hospital, calling our private office numbers and reaching out to us various different ways, wanting to be vaccinated. But I don't think that'll last forever. And I think at some point we'll realize that we needed to have started the work now to reach that goal of having 70 to 80% of our community vaccinated. So that's the goal to keep in mind. It's that we want about 80% of our communities vaccinated, and to get there will require a lot of front-end work now while vaccine supplies are still limited. So this is a Pew Research study looking at sort of national acceptance of COVID-19 vaccines and what people reported as to whether they would get vaccinated, what are some of the barriers to becoming vaccinated. And as you can see, early on in the pandemic, when we were still learning a lot, the idea of having a COVID vaccine was very popular. And about 72% of people said that they definitely or probably would get a vaccine. There's been a lot of controversy around these vaccines as some of the data is unfolded. People have become a little bit more weary on the rapid rate at which they were developed and whether or not that could have been done safely. And there were also concerns about how changes in the political administration might have affected the development of these vaccines. And I think that led to some hesitancy around acceptance of COVID-19 vaccines in the early fall. And so those rates dropped from 72% to 51%. Now, this was extremely concerning for anyone doing this work and anyone in healthcare, because we knew we needed to do a lot better than that in order to end the pandemic. The most recent survey in November 20 of this last year, it increased a little bit shortly after the election, and the acceptance rate of definitely or probably would get the vaccine was about 60%. Next slide, please. And there's a lot of factors that play into whether or not people will accept the vaccine or they believe the vaccine is safe or not. Gender, race and ethnicity, age, family income, even political party, and education. All of these are factors that influence acceptance of the COVID-19 vaccines. And I think this isn't new to COVID. This is generally true of vaccines in general. But because we're in a pandemic, there's just a lot more heightened awareness and vigilance that we have to work that much harder to understand some of the barriers to vaccine acceptance. As you can see, one of the biggest problems that we're sort of working through both locally here and nationally is that there's differences based on race and ethnicity as to whether or not people will accept the vaccine. And when you're talking about a pandemic that disproportionately affects communities of color as well as certain age groups, you want to be able to ensure that the people most at risk will in fact accept the vaccine. Next slide, please. So what we've learned here is that education really does matter. I mean, it seems like a very simple solution, but I think that it's just been so amazing how to see it work itself out in real time, to see that educating people around the safety and efficacy of these vaccines, around the science and the research behind it, and having researchers and healthcare personnel engage with communities around these vaccines has really made a difference. And I'll show you why I think that's true. So last fall, we surveyed URMC employees to see whether or not they would accept the vaccine if it was available. And about 60% of them said they would take a vaccine if it was available. So this was trending with what we were seeing nationally. So once the emergency use authorization was granted for the Pfizer vaccine, or we knew that it was pending, then your leadership got together with some of the research teams and said, well, let's put on some town halls for URMC employees, and let's have it be specific to the areas that they work and sort of their levels of training and expertise with medicine. And let's see if by educating them around how these vaccines were developed, we could move the needle and change this number a little bit. So we actually had town halls on the 11th and the 14th of December, and we had them, one for the nursing teams. And that was about 800 or so, 1,000 or so people. We had a different one for faculty and staff, and then we had a separate town hall for the ancillary services staff. And after doing that, vaccine was actually available here at Strong and UR Medicine, I believe on the 17th or the 18th of December. So that was sort of within 3 to 4 days of us having done these town halls. Now, when you look down here, you can see how successful we've been about 6 weeks after having conducted these town halls, 6 weeks after having vaccine actually here on site. So looking at the people here who work in UR Medicine, this is across all UR Medicine, not just at Strong, there are about 21,733 people who would have been eligible for vaccine in phase 1. That's the first line. Of those, about 81% of them have received at least one dose of vaccine. That means we've had 81% vaccine acceptance among staff who were eligible to have received the vaccine, and only 15% declined. That's actually really extraordinary, considering that we started at 60% just 2 months prior. And I think these numbers are actually pretty comparable with acceptance of seasonal influenza vaccines. So I think it is possible to move the needle as we demonstrated locally here at UR Medicine. Next slide, please. But I think there's an even bigger task ahead, because I think convincing people who work in a healthcare facility to accept vaccine might be somewhat easier than going out into community and doing that. So that's going to require a lot of community engagement that has started several months ago. Some of it has been led by the Center for Community Health and Prevention. One of the examples of that is having started a vaccine advisory committee that's populated by leaders and activists in the community. We've also established here in Monroe County the Finger Lakes COVID-19 Vaccine Task Force that's sort of being spearheaded by Common Ground Health, as well as Wade Norwood. And what's been just sort of really rewarding for all of us is that as researchers, we've been able to be fully engaged in all aspects of this. For example, just this past Monday, I got to participate in a Zoom YouTube live talk with the Barbershop and Cosmetology Association of Rochester, which I didn't even know existed, but just a really neat group of people who have a very unique place in our community, place of influence in our community. So I think it's going to take a lot more efforts like that, and it's things like that that was sponsored by Common Ground Health that I think is going to really help us get to that 80% we're looking for. And that's my last slide. Thank you.
Fantastic. Thank you, everybody. So we're going to spend the majority of the time we have left, except for maybe the last 3 minutes when Dr. Schneider will wrap up. The rest of the time is going to be focused on questions in the Q&A. So the first thing I need to say is that we have a lot of questions in the Q&A. We're not going to be able to get to all of them, so I apologize in advance. I'm going to try to select questions that have come up more than once in the chat. And so the first one of the questions that falls in that category relates to vaccines for pregnant women. There's questions about possible effect on fertility, whether antibodies, protective antibodies can be transmitted through breast milk to a newborn, and the safety of those vaccines. So I'm not sure who would like to comment on that, but that came up probably 4 times at least in the Q&A.
Oh, so Steve, this is Dave. We just published a study showing that women who were infected with COVID-19 or had recovered were able to transfer a substantial amount of neutralizing antibodies to their infants through the breast milk. And they did not transfer virus, even in the women that were acutely infected. So there is, I think the vaccines are probably going to do the same thing. So I think it's safe for mothers to breastfeed their children. And it will convey some degree of protection from the virus.
I know, Mary, did you want to comment on this question at all?
Well, unfortunately, I don't believe there's any real sort of world data in terms of trials, including pregnant women. They were specifically excluded. So and Nana can correct me if I'm wrong, but the ACIP basically said it's going to be an individual decision with pregnant women and their providers. And I believe in our community, most providers are recommending vaccine, given the usual calculation that all physicians do with risk and benefit. And the belief is that the benefit to pregnant women and their newborns is going to outweigh any risk that might be incurred. And I know trials are being planned. I don't know when they're going to start.
Yeah, the only thing I would add to that is that in the Pfizer and Moderna trials, they're obviously very large trials. And even though pregnant women were excluded, women did get pregnant. And there did not seem to be any noticeable ill effect on the mother or the fetus. There was a low percentage of miscarriage, but it was equal between placebos and vaccinees. So there are data that will be garnered, but so far, as Mary and Dave said, that it's an individual decision and risk benefit to that individual patient.
Thank you. I'm going to switch gears to a slightly different question. This came up a couple of times in the chat. People who have been previously infected with SARS-CoV-2 or who have already have antibodies, presumably because they were infected, Is it recommended that they receive vaccine? Nana?
Okay. Yes, is the short answer. If you've recently, we do not recommend that people get vaccinated while they have active COVID disease. So if you are, if you've just been diagnosed with a test or you are symptomatic, it's recommended that you wait until you're out of the isolation period and your symptoms have resolved. And indeed, you can wait longer. It's believed that you will probably have active antibody for at least 90 days. And so you can wait for a time to get vaccine, but it is recommended that people receive the vaccine. It's not known for sure, but there's some indication that the vaccine may provide a better immunologic response actually than having the disease, and it may be more long lasting. So it is recommended that people do become vaccinated.
Thank you. There's several questions that relate either directly or indirectly to, I suppose, social interactions after one's been vaccinated. So they're questions that are either, if you have two vaccinated people and they're in the same room, can they chat to each other without a mask on? Or if you have a grandparent who's, you know, over 65 and maybe wanting to visit grandkids, what should they do? So some of those I realize we don't have perfect answers to. And I'm certainly, anyway, so any of you feel like fielding a question in that general space?
Yeah, I can get us started. I think one of the important things to remember is that with any of the vaccines being studied, asymptomatic infection has not been studied. And so what we don't know is if you've been vaccinated, could you be carrying the virus to somebody else who's vulnerable? So that just has to be kept in mind. You know, hopefully if you're a grandparent talking about visiting your grandchild and you've been vaccinated, we all hope that would provide you protection from getting sick. But, you know, is it possible you could bring that virus to the family that you're visiting? So we do continue to recommend that people continue to mask and use social distancing. I think each individual family will have to make some decisions about who they want to see and when. My advice to people is let's try to let the pandemic calm down a little bit. We do see some encouraging trends that viruses around the country are on the downtrend, and I would be much more comfortable visiting after vaccination once I know that the virus is not so prevalent in the community.
Good answer. Okay. The question, several questions that really relate to, well, just uncertainties about vaccination. So for example, what's the length of immunity? Do we have any idea about how durable vaccine elicited immunity is? Do we, what do we think about vaccine resistant strains? And do we think this is eventually going to turn into something that's a little bit more like influenza vaccination, where we end up having to receive regular updated immunizations for a pathogen on a fairly frequent basis?
Maybe I can get it started. We don't really have much long-term evidence that I know of on the longevity of immunity induced by vaccination. We have some evidence on immunity elicited by infection, and it looks like it's remained steady out to 6 months, which is encouraging. It goes down a little bit initially, but then becomes more stable.
Does anybody else want to comment on whether, I mean, it's just a purely speculative question, but whether you think we'll end up with a situation where maybe we end up with frequent, you know, I don't know, every year or every couple of years, who knows, but updated immunizations for COVID?
So I can just make one comment, which is, and please all the other people correct me if I'm wrong, but I believe the NIH is working on a pan-coronavirus vaccine. So one that would protect against all of what we currently have in terms of coronaviruses and potentially against new and emerging coronaviruses. So hopefully that type of vaccine would not need to be updated frequently, but I'm only going by sort of what I'm hearing little bit of reading and not much hard data.
I think, Steve, the jury's still out on that question because we don't yet know what will happen as people develop immunity over multiple seasons, which I think is really going to drive whether or not this becomes something that continues to cause severe illness like influenza does every year, or something that becomes more like the common cold, which is what coronaviruses usually do. So I think we'll know over the next couple of seasons how having longer lasting immunity affects the ability of this particular virus to cause severe disease. And that will answer the question as to whether or not we need yearly vaccinations or we can stop doing that.
Thank you. There's another question, several questions about vaccines in folks over 65, and at least one of those is related to an action that was announced today where the German government indicated that they are not going to recommend the AstraZeneca vaccine in people over 65. And just to point out, the AstraZeneca vaccine is not yet approved in the US anyway. So it's a little bit of a hypothetical question, but it's likely to come up. So I guess broadly just curious about people's thinking.
Yeah, I'll take that because, you know, we've certainly been putting a lot of effort in on the AstraZeneca vaccine here in Rochester. And it's a little frustrating in the way it rolls out. The initial press release by the German authorities was that the AstraZeneca vaccine was only 8% effective in people over the age of 65. And nobody even knows where they got that. It was completely inaccurate. And, you know, I'm fairly up to date on this data. So and they've reversed it and said, well, no, actually, we just don't think there's enough data. And that may be true. So in the Pfizer trial, and I can't comment on Moderna, they did do a sub-analysis where they said that the Pfizer vaccine was over 94% effective in people over 65. And it was a big trial. And they had one case of infection in the vaccines and 19 in the placebo. So they had 20 infections overall in people over 65. So their confidence intervals that it was effective were from like 60 to 90. In the over 75 group, they had very little data as well. It appeared to be effective, but the confidence intervals are enormous. So when the AstraZeneca/Oxford people actually published their efficacy data from the UK and Brazil, it was a much smaller study. And so they do not have as many people over the age of 65 in that study. In addition, in the publication, and I guess I haven't scrutinized all the appendices, they didn't give age-specific efficacy. So I think that the reality is we don't have that data. Now, one of the concerns for the trials, and this is a concern moving forward, the AstraZeneca study in the US required 25% of the study population to be over age 65, just specifically so they could answer that question. But what's also true is the infection rate is lower in people. It's more devastating, the illness, but the infection rates are lower because generally people are retired. Maybe with age comes wisdom and people are sensible, they stay home. And so we always knew the infection rate would be lower. And now what's happening with the AstraZeneca trial and the EUA vaccines is people are rapidly being unblinded because they are eligible for receiving Pfizer or Moderna. And so we can't not unblind them. We want them to be protected, yet they can't be endpoints in our study anymore. So I actually am worried that we will not have enough data to answer the question definitively. But the last thing I'll say is that the antibody response, the neutralizing antibody response in the over 75-year-old group with this vaccine looked terrific. So,
and I think that's a really important surrogate, right? That is the measure we use for influenza and for other pathogens to predict what we expect to be protective.
And it's important to point out that other than Pfizer, none of the trials for any of these vaccines will have the data for older adults that we would like to see, because the trials are still ongoing and older adults are being vaccinated right now. And so we're going to have this problem with all these vaccines, and we're going to have to make some clinical judgments based on the neutralizing antibody results.
Which seems the most reasonable. I'm going to just, we have time for perhaps one short question, and the one I'm going to ask, I'm hoping we can answer very quickly, but maybe not. So a couple of questions about people who have prior history of allergy in some form or other, and what do you recommend for those folks? And similarly, for somebody who maybe is on chemotherapy for cancer, what do you recommend for them? Angela?
The allergy question. So we do actually have an allergy team here headed by, I think it's Jessica Stern, who is looking specifically at this question of people who have history of allergic responses to vaccines in the past, and whether or not it's safe for them to get the Pfizer. So I think you can reach out to their team here at Your Medicine if you fall into that group or you know someone else who does. Our current recommendations is that if you have had an allergy to a previous vaccine, or if you had a severe allergic response to this vaccine, the Pfizer or the Moderna, not to get the second dose. But if you're someone who just has a history of allergies to other things, discuss with your doctor first, see what they recommend, and make sure that you're getting that vaccine in a supervised environment where there is a physician and a nursing team available to assist you if you need it.
That's great advice, Angela. Thank you. Just in the interest of time, I'm going to have to stop the Q&A now, and I think we are going to go, we're going to return to Dr. Schneider for just some final comments.
Thank you, Stephen. Well, just as I promised, wonderful to see a collaborative science being immediately translated into an invaluable, healthy outcome. To the panelists, thank you for being both informative and offering an encouraging session. And thank you also for the work you do every single day to care for our community. To the viewers, we hope you enjoyed the program, and we hope absolutely to have feedback about it. Please take a moment to share your thoughts about the session. A link for a brief anonymous survey will appear on the screen at the end of the webinar. Simply select Continue to enter the short survey. Additionally, plan to join us for another Rochester experience on Thursday, February 11th, 4 days post-Super Bowl at 12 p.m. for our next Experience Rochester event. It will feature Pulitzer Prize-winning author and University of Rochester alumnus Stephen Hain, and the session content is Slavery, Race, and Black Lives Matter movement. Enjoy the rest of your day, stay diligent, and stay well. Meliora.